Okay, thank you both for being here. My name is Amanda Finley. I started COVID-19 Long Haulers Discussion Group. We are here today to talk about pediatric long COVID. Friendly guest, introduce yourself.
I'm Thomas Nguyen. I am a outpatient pediatrician. I practice in Northeast Ohio, currently in private practice. I have about 16 years at my current location.
Awesome, thank you.
And I'm Frank Han. I am a pediatric cardiologist with the University of Illinois Health System in Illinois.
Great, thank you both for being here. Let's just jump right into it, okay? First question, is the weird lump my kid has on the side of their neck a thing that others have experienced? They're calling their pediatrician in the morning to see if it's still there, but they just wanted to know if you've seen that in other kids.
It is a very common question we get, and I can tell you in most cases, it's a benign condition called reactive lymphadenopathy. However, just like anything else, it could be a sign of something else. And so the important factors that we need to consider are the age of the patient, any other symptoms that might be going on at the same time. And most importantly, is it tender? Is it red? Is there a lot of pain when it's pressed on? But it is a bread and butter type of situation that pediatricians deal with on a regular basis. And I would reiterate, in most cases, it's completely benign and something that will just go away over a few weeks.
Good to know. And this is something I think, especially for both of you, what do I need to communicate to my pediatrician about long COVID concern? And how do I do that without being labeled as some kind of hypochondriac? It's a loaded question.
I think this is a challenging one for all of us because people are coming in with different ideas and expectations on what I can provide, in addition to what they have seen and what they believe exists about COVID. But if they are truly interested in learning about it, I will take my time and do my best to explain my personal experience, what the Academy of Pediatrics recommends, and what the expectations are going to be in the intermediate to long term. The key in this situation is, what is your specific question going to be? Is it how worried do I need to be of my kids, about my children? Do I need to change my my day-to-day living expectations because of what is out there? And those are decisions that are best made locally with somebody you know and trust, and to address whatever specific concerns they might have. It is a very broad question. It is a question we get all the time. And obviously the answer we give is going to change based on how old your kids are, what they're involved in, what are your expectations for things moving forward. And the answer I give today will be different than the answer I give in October, mostly because we know things are going to change. Our therapeutics are going to be different as time passes, and also the relative risk of getting the illness is going to change as time passes. So it is a totally fair question. It is very difficult to answer without more specifics.
That's something we actually addressed with Taylor Nichols a few months back. What to expect in the ER? That's an entire town hall in and of itself. What things are there any things specific to that in cardiology, Frank, that you would add?
So the cardiology has a similar conundrum in that there's not a blood test or a cardiac test that can say that, oh, this is long COVID, but we can do things like stress testing and echocardiograms to look at what we know are objective findings. And so where a cardiologist can be useful based upon the current knowledge of long COVID is helping your child figure out what their functional capacity is and seeing if they have any associated heart conditions or some findings that you can quantify that might be responsible, for example, tiredness, heart rhythm problems, or difficulties with exercise. So it's like Dr. Nguyen said, is quite a broad question, but the way to go about it in a cardiology office is just have the discussion centered around something along the lines of, well, let's figure out how my child is doing with their exercise and try to quantify that objectively and then take it from there.
Great, thank you. So here's the third question. I've seen some research, mostly preprint, about those things with like with Ehlers-Danlos syndrome and autoimmune thyroid conditions having worse long-term outcomes from COVID than those without those conditions. Did those preprints ever make it through review? And what should I be aware of and looking for in my kid who has an established autoimmune condition already?
The first part of that question is kind of hard to answer. I would encourage that person to discuss their concerns with the subspecialist that is managing that particular subset of problems. The second part, it does seem to be true that having an underlying autoimmune condition would make you at greater risk for having more complications related to COVID. So I would just encourage anybody in that situation to make sure that their disease condition is under optimal management, whether it's type 1 diabetes or asthma or any number of autoimmune conditions that we deal with on a regular basis. Juvenile idiopathic arthritis is again, it's another one. A lot of the medications we use to treat those conditions do cause immunosuppression. And so being in optimum health does seem to be correlated with better outcomes overall. And that's what I would encourage anybody in that situation to focus on.
Any thoughts, Frank?
I second that. I think that the preprints that the original people are referring to are probably the study by Tesh, but from what I can see based on how the state of the article is it's probably still in peer review and it's not in its finalized form yet.
Okay. So keep an eye out. And that's another thing. We're overwhelmed with information like that. It helps to make sure that we're looking at things that are from a reputable source, and not just like the publications that have just popped up, like just like and published the one thing. I've seen a lot of that, and anyhow. So let's get on to the next one. What are the rates of children developing long COVID, and what are you seeing in your practices?
This is a very difficult one to answer too, and it is mostly based on how loosely we define long COVID. Generally speaking, we're talking about symptoms 12 weeks or beyond an acute COVID illness. But the challenge with kids, there's two challenges. One is a lot of them have minor symptoms or never get diagnosed with COVID in the first place. The other one is, especially with the younger kids, long COVID symptoms are non-specific. And so younger kids might not verbalize the things we're looking for. Most commonly, fatigue, can't taste, can't smell, brain fog, headache, abdominal pain. Those are going to be the most common ones that we see. And at least according to the AAP, the rates are somewhere between 4 and 66%. That's the latest I've seen. That was from late 2022. It's not 66%.
No.
I can tell you that from my experience, but somewhere in the 4 to 15% range, that's probably accurate. I can tell you personally, something like if I had 1 or 2 more patients with a chief complaint of headache coming in every month, I probably wouldn't notice that. But could it be related to long COVID? Absolutely, right? The easiest way to tell for me personally is when I have a patient who is an athlete in a sport that has a very specific objective measure, like a 400-meter runner or a swimmer, where they notice that they are 10 seconds off from their best time, for example. And that's the easiest way for me to recognize it and to tell if they're getting better. So that's what we're seeing. We're seeing, we are seeing the things like fatigue, abdominal pain, headache, but I can't tell you if it's long COVID related. And unfortunately, we just don't have the resources, because it is true, there isn't a great test technically there is a blood test that can tell you if you've been exposed to the virus previously, but almost everybody would be positive on that test at this point. And so that's one of the challenges that we deal with, between that and not having enough access to subspecialty care. Trying to make sure that the ones that we do refer are the ones that need it the most, and dealing with that on a regular basis. And I know that the adult world deals with this too, but I'm focused on pediatrics, and cardiology, or at least locally, is not bad, but physical medicine and rehabilitation, long COVID clinics, those are all talking several months in the future for some of these patients, and that's a huge challenge.
How about you, Frank? What are you seeing in cardiology?
So in cardiology, the rates seem to be on the lower side of the numbers that were quoted. So around 1 to around 10-15%. I think the British Office of National Statistics quoted a rate of long COVID of around 1%. And what these patients are coming in with is a mixture of shortness of breath or palpitations or exercise intolerance. And so the testing that you'd see in a subspecialist office would be things like an ECG and an echocardiogram to see if anything can be objectively pinned on to that might cause those symptoms. But the rates are thankfully not 66%, just like Dr. Nguyen reiterated there, but we're still seeing a fair proportion of kids coming in with needing assistance for that.
Frank, can I ask you a question?
Yes.
At least locally, we've seen less MISC as we've progressed from original to Delta to Omicron. Have you noticed a similar experience over there?
True. So over in we have multiple hospital systems, and we're generally not seeing MISC anymore.
Good.
Okay, that's really good to hear. But I was just talking earlier with someone about how at the very beginning of the pandemic, before anything was shut down, we were talking about Kawasaki. And then it was just like we collectively forgot within a matter of a couple of weeks, oh, it can affect kids too. I have a friend in Kansas City whose child was diagnosed with Kawasaki. So that's good to hear that you're seeing less of that.
Amanda, my first patient that I ever diagnosed with MISC presented a lot like Kawasaki.
Oh, really?
In fact, that's what I sent her to the emergency room to rule out.
Yeah.
And I was a little surprised when it turned out their ejection fraction was affected, and they had to spend a week in the hospital. But I'm glad we're kind of past that era for sure.
Yeah, I have several people in my group, adults, who were diagnosed with MIS. It's not pretty. And this is a great one. My child is very young and doesn't communicate verbally. What should I be looking out for?
So this is the challenge of pediatrics, and what I would say is nobody knows your children better than you do, and so it can come across as something minor, like for example, you have a play date planned, you're going to go to the playground and have fun, and they just aren't feeling it that day, and that drags on for several days. It could be their tummy hurts and they don't want to eat. It could be they're acting tired, and it would focus back on, like, if your kid's not acting right and you're worried about it, then maybe they need to be checked out by somebody else who could do some lab work, or say, like, yeah, something is wrong here, or the opposite, do some lab work, say, hey, everything checks out, I think we're okay. That's kind of our role, and we do that a lot. But I can assure you that I don't know your kid better than you do, and so if you're worried, don't be afraid to ask. That's what we're here for.
Anything from a cardiological perspective?
So similar advice. We are tasked with determining if 1-month-old infants have heart failure, and it would be cool if those 1-month-olds could tell us, hey, I have chest pain, man, but they're 1-month-old, so they're developmentally not expected to be able to do that. So we're going to be relying on the parental observations, because they have seen their kid the most. They've seen their kids more than the physician has, and then using those observations and what the cardiologist might see in the office to take it from there.
Yeah, I actually got it twice. I've gotten it for my son. The first time was before anything was shut down. We were out driving around handing out bags to the homeless one day, and a 7-year-old does not stay quiet in the back of a van that long unless something's up. So we got home and I asked him, "Do you want to stay home tomorrow, buddy?" And he said, "Yeah." He just looked like a wilted flower, and I didn't know what it was at the time. Let's see. When is it safe for my child to return to sports?
So for the AAP, current recommendations focus on the starting off triaging by the severity of the initial COVID symptoms. So if there was pretty severe COVID symptoms defined as the person needed to stay in the intensive care unit, then there was going to be the exercise restriction for several months, and then consideration of obtaining a cardiology clearance, and that would involve an ECG and echocardiogram, potentially adding on a stress test. If it was moderate disease, meaning that there was greater than or equal to 4 days of fever, greater than 100.4, myalgia, chills, or tiredness, or a hospital but not ICU stay, then that kind of patient should consider a evaluation with their primary care, updated physical, and EKG, and evaluation of how their symptoms are. And then the not symptomatic or someone who had mild COVID would have a follow-up visit, abbreviated physical, and then if there are no concerning symptoms, then they can consider gradually returning to their prior sports. But if there are concerning symptoms, then considering more testing with their primary care and involving a subspecialist if needed.
Okay. This is something that's sort of tangential, but I've heard this a lot with a lot of parents. What educational options do we have? My child has missed so much school, and I don't know what to do.
Yeah, I mean, this is more of an education
Yeah.
question than a pediatrics question. We would focus on the things that we can control. Is there a developmental concern? Is there ADHD? Is there something that we can act upon to maximize your child's success? Okay. If it were to happen again where we had to bring our kids home from school and do remote learning, okay, we know that a lot of parents aren't built for that. They have to they have to sit down and teach their kid advanced math, and they just can't do it. And it's a struggle to do it electronically. And obviously the kids that don't have resources are going to struggle more. And the good news is that while there has been some at least measurable academic performance issues, overall the kids actually are doing okay.
Yeah.
And so for the most part, I think that this is one of those things where if you are stuck at home with your kid and you're not built for that type of thing,
I lost Taylor once. I just sat there and told that jokes.
stuff, we're here to help for ADHD referral, right? But anything more complicated than that, unfortunately, I'm with the parent here. I wish there were more resources. I wish every kid had a private tutor. Unfortunately, we're not there, and so we have to deal with the resources that are available and make the most of what we have. The good news is, like I said, there hasn't seemed to be a huge drop off academically, at least for most kids. That doesn't apply to individuals, of course, but I think we're going to be okay.
I think that was my big thing. I would rather keep my son home, and I'm not going to worry about the academic performance. I would rather they all get the chance to make it there. So, that's good to hear. Okay. How do I handle COVID precautions when my child's school is just back to pre-COVID normal? That's a tricky one. I'm actually in the situation myself. I don't know what to do.
So, I think a lot of the schools about a year and a half ago, after that amount of time of masking and pushback from parents, were kind of feeling a lot of pressure to reduce their mask requirements. And what we saw over time was, they would say, we're going to remove our mask requirement now, but we may reinstate it based on prevailing circumstances. For example, if the test positivity rate were to go above 10%, okay, which is not an unreasonable recommendation. The problem is most jurisdictions have stopped public health reporting, and so how are but am I still with you?
Yeah, okay.
Okay.
Yeah, I was there, I'm sorry.
But it is one of those things where you have to make a judgment call based on, how much you trust the school system. Do they have some type of air filtration improvement? Will they open the windows? Do they run a HEPA filter in the room? All those little things add up. And how aggressive is the school administration, the school nurse, going to be to send people home if they're sick? Are they going to? At least I know in the state of Ohio, if you spend too many days off, you have to get a doctor's note. Whereas 3 years ago, if you spent too many days off, you just spent those days off and it was no big deal. And those types of things are frustrating for me because I don't want to spend my days writing notes for kids in school, right? If you have a positive COVID test at home, stay home for 5 days, come back for 5 days with a mask. That's the current recommendation. It hasn't changed in 2 years. But I do feel for these parents that are concerned about this. The good news is, and I think I can say this, COVID does affect kids less than adults. It still affects them. It affects the adults they live with. But I would rather be a kid with COVID than a grown up with COVID. And that's something that's been true for 3 years, and it'll probably be true next year. That's it. That's all I got.
It's been really tricky to navigate. Any thoughts, Frank?
Oh, I'll second what he said. I don't have anything better to add than that.
Okay, got it. Let's see. What signs and symptoms should I be looking for with any cardiac issues?
So for the older kid who can communicate, they're going to be able to describe similar symptoms that adults might describe, such as chest pain, shortness of breath, palpitations, meaning a fast pounding heartbeat, dizziness or troubles with exercise, or some mixture of those things. With the younger kids, it is possible they might tell you things like their chest is having ouchies, or their chest is beeping, or something along those lines, based upon whatever level of vocabulary their kid has. And then for the younger infants who are still working through bottle feeding, their main exercise is that bottle feeding. And so if they were to have cardiac issues, their symptoms would be, for example, getting pale with their feeds, sweating with feeds, or having difficulty taking the usual quantity of feeds, or a mixture of all of those previous symptoms. And so if you were to see those things happen, then it would be worthwhile getting checked at your primary care and involving a subspecialist if needed.
I'm very grateful mine is 10 and can talk now. Thinking about going through this with an infant. Oh my goodness. Let's see. Should I have my child get the new booster this fall if it's available? And should it be given at the same time as an RSV vaccine if that's available?
Yes. And I actually do think there would be benefit to wait for it's called the XBB 1.5 version that's probably going to come out sometime in October. The Omicron bivalent that is out currently, it's great at preventing death and severe illness, but it's not as good anymore at preventing the minor illnesses and infections. And so, waiting just a couple months to get the better one, I do think is a good call. We'll point out the RSV vaccine is not technically a vaccine it's a monoclonal antibody, kind of like Evishield and Regencov that were available a couple years ago. It does not elicit an immune response the same way as the vaccine does, but it does seem to be a great product. Some questions about insurance reimbursement that we won't know quite what the answers are until we get a little bit later into the season. It is $495, but RSV, one hospitalization is going to be 10, 20 times that.
Yeah.
So yes, you can get them at the same time. I haven't heard any reason why you couldn't. There was no the most similar product to Beyfortus was Synagis, has been out for about 20 years now, and there was no restrictions with giving those two together. So while I haven't heard anything specifically, I didn't anticipate any contraindication to giving those two together.
I had RSV several years ago, and wow, it knocked me down for a good month and a half. It was stuff. Another reason to wear a mask. So, where are some long COVID clinics that work with children, and how do I find and access
them? I am going to send you a link through the chat.
Yay.
I don't know if you can see that.
Oh, thank you.
Okay.
Oh, yeah.
And you're probably familiar with that, but apparently there's 20 long COVID clinics in the United States. It's great if you're close to one. The closest one to me is at Rainbow Babies in Cleveland. So for my patients, it's about a little over an hour to get there. Our group as a whole has referred a few patients in that direction. I can tell you that in most cases, for a long COVID patient, we don't have to refer to a long COVID clinic, because if their issue is chronic headaches, we can refer locally to a pediatric neurologist. If their issue is abdominal pain, we can refer them locally to a pediatric gastroenterologist. So most of the time we don't have to go to the multi-specialty group, but it is nice to have it there for those situations. I can tell you that if you live in a place that is not near one of those things, start with your pediatrician. Hopefully, especially if you're rural pediatrician, you're used to dealing with complicated symptoms that you can't just refer to somebody 20 minutes away and get it in a couple weeks. It is frustrating for pediatrics, but I'm speaking to adults who have long COVID symptoms. Some of the parents I deal with, and they have it much worse. And so I sent you the link. Maybe we can add it to our listing.
Yeah, that would be great. Thank you. That's I didn't know there were 20. That's great to hear. The last I checked, there weren't nearly as many. My child has been having GI issues ever since having COVID. Is this related? And are GI symptoms common after COVID?
The best answer I can give is maybe. And similarly, our treatment would be based on what additional symptoms are present, the timing of the symptoms. Is it related to eating? Is there constipation or diarrhea? Does it seem to be related to stress, lack of sleep? The most helpful thing when it comes to GI, the second part of this question is how can I best prepare myself? If you could take a food log, take a food diary, and give us a sense historically of when the symptoms occur, how long do they last for? What are the nature of the symptoms? Is it a stabbing pain, a burning pain? Is there nausea associated with it? What did you eat recently related to that? How long did it last for? Okay, what made it go away, if anything? That kind of information is very helpful to us because the most common types of abdominal pain we deal with include irritable bowel syndrome, nonspecific abdominal pain of childhood. Sometimes we deal with things like celiac disease. And all of these things can be evaluated for, tested for, and treated. Some of these things your pediatrician might even try to treat, at least initially, because it does take time to get in to see the specialist. So at least the early stages are treated just the same as any other chronic abdominal pain, whether it's lab evaluation, endoscopy, imaging studies, trial of certain types of medications. These things still exist, and so we shouldn't feel like it's a hopeless situation. There are good treatments available for all of these things. It's just a matter of getting somebody you know and trust to help you, guide you through that process.
I don't know if you wanted to chime in, Frank, because sometimes people might confuse GI symptoms for what are actually cardiac symptoms. Is there a good way to discern that in children?
it's tough the younger the child is. So the one way to go about it is to make a symptom diary with your kid to see if the symptoms are triggered with exercise. It's not completely foolproof, and it's not really black and white, but it can help you and your subspecialists figure it out. And for the patient who has these GI symptoms, you can also look at things such as fluid weight. You can look at if the patient has been having difficulties eating. You can look if they have troubles with doing the same physical activity that they used to be able to do. And ultimately, we don't mind getting consultations to double check if there is a heart issue that may be contributing to the GI symptoms. So no harm done if a cardiologist is asked to double check.
Yeah, that was something that we talked about with Taylor in regards to going to the ER. You know, you might not regret going in, or you might you might regret going in, but you're going to regret not going in even more and not checking it out, just in case. Yeah. It makes more sense just to check it out. How can I best prepare myself when going into, well, we already kind of talked about this. What can I do to prepare myself best to see a pediatrician or specialist? What would make it, what makes your day? What can we do to make it easier for you?
Frank, why don't you take that one?
Yeah, do the coding.
Sure. So, I mean, the main thing is just to have a description of the symptoms. And for extra bonus points, if you have your medical records from before, that's great. It makes it easier in places where there's hospital systems that are able to see the medical records of the other subspecialists or pediatricians who may have seen the patient. But no, nobody's going to look at you funny if you didn't bring your old medical records from the olden days. So ultimately, just come to your visit ready to describe what symptoms you're seeing, and that will go a very long way.
Yeah, and especially now that you can access my chart on your phone. I did that with my endocrinologist. I just pulled everything out in here. Here's this thing from 10 years ago you need to see, buddy. And you can gather all of your records into my chart from different facilities over time and geography. Also kind of scary. My child is autistic and we have a hard time keeping masks on and doing other precautions. How can we best protect him?
So this was something that came up in Ohio in late 2020 when our governor, interestingly, Mike DeWine, Republican, but took COVID precautions fairly seriously.
Yeah.
So, they instituted the mask mandate in schools for kindergarten and up. There was a specific carve out for patients with autism because this is a difficult thing. And then you end up spending your whole day putting the mask on. The patient might be agitated about that. And that was just something we accepted. Now, fortunately, most kids in those situations would be in a special ed class, which is smaller, lower population. And still considering the risk versus benefit of being in school, we would tell you send them to school. That's good for them. The best way to protect a patient in that situation, I would say a couple things. One is get vaccinated. That's pretty straightforward. I know some people don't want to hear that, but at least right now it's our best intervention. The other is, from a more like universal standpoint, there are things I want to do with my family, right? Is it safe to go to the movies? Is it safe to go out to eat? Is it safe to go to a baseball game? And in general, outdoor activities are going to be safer. You have an infinite amount of oxygen and air. It's constantly turning over. The risk of outdoor transmission, while real, is much lower than indoor transmission. Okay. For things like going to the movies or going out to eat, it's the same menu at 2 p.m, and there might only be 2 or 3 people, other people in the restaurant. So you have to take advantage of situations like that. Going out for hibachi, they have that giant sucker fan over your head. Okay. Again, it's going to be safer than eating in a small diner where people are right on top of you. And then going to the movies, don't go to Barbie the weekend it opens. Wait a week or two. And again, go in the afternoon when it's less busy. These are all things, like little things you can do to reduce your risk and still have a fulfilling experience with taking your kid out and having fun. That's what I'd recommend to my parents that truly want to know about this stuff. Airplane, probably not the best time to do that.
Yeah.
But again, it's a judgment call. And if you like you're flying to Chicago, you'll be wearing a mask, I'm sure. So that's where it gets a little bit tricky. And then you have to make that decision on your own. But yes, we have patients that deal with autism spectrum, and we try our best to encourage them to enjoy things without making them feel guilty about going to Disney World, for example. That's a great question. When I saw that, I thought, we've been in this situation, and there are plenty of patients that we have to advise in things like this.
My son is autistic, and we were talking a couple of years ago. He was like 4 or 5 years old. He did not wear jeans. He did not wear jeans. And I looked in the closet to get him dressed one day, and it was just jeans. So I asked him, buddy, do you want pants or jeans? And he's like, I like penguins. But there are so many considerations that go along with autism, these sensory issues, that it just makes it hard, and you have to roll with it. Let's see. Sorry. My daughter is struggling with depression on top of the medical conditions. She's mostly homebound. How can we best help her, and what resources are available?
Depression is something that we have been dealing with for years, and we do an okay job with it. Obviously not as well as we'd like. We need more therapists, we need more counselors, we need more pediatric and adolescent psychiatrists. But at least the younger generation of pediatricians were trained in an era where general pediatricians can take that first step and discuss the risks and benefits of medication management. There's FDA approval now for SSRIs in kids. This makes it a lot easier for us to at least take that first step, because that doesn't require waiting 7 months to see a psychiatrist, and we can get you started, and maybe at least get that first step to get out of bed and walk the dog around the block. The challenge, again, we don't have enough specialists. We don't pay pediatric and adolescent psychiatrists enough. We don't pay developmental pediatricians enough. And we certainly don't pay counselors enough. So until we figure that problem out, this is going to be a massive challenge. To the patient or the person who asked this specific question, I would say talk to your pediatrician first, because they probably have a good answer, at least locally, to get you started, whether it's medications or counseling or therapy or something. That's what we're here for. That's why we went into primary care, is to help the patients we know to best enjoy their life.
And I don't know, I've seen that a lot in the long COVID kids discussion groups, where it's a struggle. It's their birthday and they want to do something, but they're in bed all day.
There is a subset of psychology related to chronic illness. I know Akron Children's, take care of yourself. We're good. I know locally Akron Children's has a PhD psychologist that just deals with kids with chronic illnesses, and certainly long COVID would qualify. Mostly what she does is pediatric cancer patients, but if you have a resource like that, that is also a great place to go through. But you can always start with your pediatrician. Like I said, that's what we're here for.
Okay, that's good to know. Thank you. How do I talk to my children? How do I talk to my children about COVID and long COVID? I don't want to scare them, but I want them to know what's going on. They're 5, 7, and 10 years old.
Yeah, this one's also very difficult. I think as a parent, you first need to find resources that you trust, because as we found out over time, there is a lot of information out there that is can be in either direction, not helpful or not accurate. Once you've developed that knowledge base yourself and you feel like you understand it well enough, that's the time that you can rope your kids into it and let them know, basically, there's a disease out there. It's dangerous for some people. We need to change the way we act, but we don't have to stop doing everything we want to do. that's probably enough. And then in the course of life experience, hey, your son will come home and say, my friend's not at school, he has COVID, or my friend's dad hasn't been able to work for a couple of weeks because he has COVID. That's when you have opportunities to kind of explain things further, when there's actually some personal connection that the kid can feel, because otherwise you're going to have a hard time getting through to them, because it's like, why are we doing homework in the summer? Okay. So that's what I would say is, take those opportunities as they come up, and explain things as they come along to the best of your ability. And again, you're going to see your pediatrician once a year. If you need us to explain things to you, we're more than happy to do that.
Okay. I don't know if I'm not really a Disney person, but I got really excited when they made the movie Raya and the Last Dragon. I studied Southeast Asian archaeology in college. I was like, oh yeah, I gotta check this out. Oh my God, it's a movie about a global pandemic and mass grief. And watching that, I watched that with my son. It's pretty good. So,
it shouldn't have been an armadillo. It should have been a pangolin.
Right, I know.
That's the one thing about that. But I did like the kid with making the buns in the back of the boat.
Yeah. And the guy, the armadillo knot thing, its name was Tuk Tuk. I love it. So, and I guess if you do want to comment, you don't have to. But last week, NIH said in a statement that children aren't affected by long COVID. Any thoughts on how parents can advocate against that?
Frank, you want to start with that one?
That's really tough. I think that, and I'm not Senator Richard Pan, so I don't have the experience in organizing that level of a response. But I think that multiple subspecialists and multiple primary care pediatrics organizations and individual physicians have now seen long COVID in kids. We're quite grateful that long COVID doesn't affect kids as horribly as it does adults, but there's still a quantifiable risk to children to get this disease process. So I think at the most basic practical level is connect with your pediatrician first, or family practice if your child is still having symptoms, and then at the county, city, or state level, I think that the most effective thing to do is probably to start organizing as groups and then talking to your local elected officials or state officials to say, well, there are a great deal of people affected from this condition, and they deserve to be heard.
Yeah, and we can do all of this. We can do all of this over the internet now. We're connected in ways we've never had before. It's pretty cool to watch it all unfold. Any parting thoughts, either of you?
Yeah, here's, and this isn't, I have to be very careful with how I state this. I have seen patients with long COVID in my practice. I can tell you that in most cases, the best treatment is to support the symptoms, and over time, in almost every case, every kid I've taken care of has gotten better. Okay, so that's it can take several months, but even the more frustrating things like lack of taste or smell, in most cases it goes away. I can't say every case because there are some that are still dragging on, but a majority of the kids that I take care of, there is light at the end of the tunnel, and it's, being the best parent you can be, getting them the support they need until their body takes over and it gets better. Like I said, it's not going to be every patient, but most patients, that's been my experience.
It's good to hear. Any final thoughts, Frank?
And so the people who in our clinic who maybe have come in with functional limitations or findings on their echocardiogram, those guys have also gotten better. Maybe has taken a long time. Maybe we've had to support them temporarily with medicines or to help them control some heart rhythm issues here or there. But from the pediatric cardiology world, at least in our healthcare group's experience, there is also a cardiology light at the end of the tunnel for these kids.
That's great. That's really great. Well, thank you both for agreeing to my shenanigans. I appreciate it. I look forward to seeing you again. I'll catch you on the flip on Twitter. Have a great night. Bye.
Thank you.